that better? Yep. Okay, so I'm going to talk about von Willebrand disease research in Ireland. So by way of background, this is Eric von Willebrand disease. Eric von Willebrand. So he described this disorder back in 1926. He described the case of a 13-year-old girl who developed fatal bleeding with her fourth period. And the little girl came from a family on the islands. So these islands lie between Finland and Sweden, just here, this archipelago. They're actually an autonomous region of Finland. The language in these islands is Swedish. And we have a great meeting, which happens out here every 2 years on this island of Foglo, where Hordis, the original little girl, came from. So it's an interesting place. This is the family tree of the first case of von Willebrand disorder. So this is Hordis, the little girl I mentioned just here. And as you can see, all through the family tree, there are people with significant bleeding. The thing that caught von Willebrand's interest was the fact that, unlike hemophilia, obviously, if you look at this family tree, you can see that males and females are both affected. And the kind of bleeding was different to hemophilia in that there were heavy periods and nosebleeds rather than joint bleeding. So what is von Willebrand factor? Well, it's a clotting factor that's in the blood. And whenever you damage the blood vessel wall, the von Willebrand factor really acts like glue. So it sticks to the area where the blood vessel wall has been damaged, and then it causes platelets to stick down. And that's what stops the bleeding from happening. That's called primary hemostasis. And von Willebrand disorder is any defect in von Willebrand factor that causes a bleeding tendency. So that can be a reduction in the amount of von Willebrand factor and or a qualitative functional defect in von Willebrand factor activity. So patients with von Willebrand disorder are at increased risk of bleeding, as you can see just here. So nosebleeds particularly can be problematic, but there are also a lot of other bleeding areas that can be affected. So easy bruising, heavy menstrual bleeding, as you'll hear from Michelle later on, postpartum hemorrhage, right down to joint bleeding in patients who have got severe von Willebrand disease. And of course, one of the key messages that we have to try and get out there to the general population is that bleeding disorders aren't just for boys, that girls bleed too. And that in particular, women with von Willebrand disorder can bleed for many, many years before anyone twigs that they may have a bleeding disorder. So why is von Willebrand disease important, and why is this week important? Well, this is the commonest bleeding disorder in the world. You know, probably something like 1 in 1,000 people have reduced von Willebrand factor levels and a significant bleeding tendency as a result. It affects males and females, and it affects all races around the world equally. But in spite of the fact that it's so common, you know, it's not very well known at all. So there have been a number of campaigns by different organizations around the world to try and address that. Okay, so that's the background. That's von Willebrand disorder worldwide. What about von Willebrand factor and von Willebrand disease research in Ireland? Well, so this is a bit of a trip down memory lane. So back in 2005, I was leaving London. I was looking for somewhere to go to work. And so I was interested in doing some academic clinical work. And so I thought Dublin offered a lot of opportunities. In particular, we had what was then the old NCHCD. And then we had just across the campus, if you like, we have the Trinity College Institute for Molecular Medicine. So I thought that these two together gave a really good opportunity to set something up in Dublin. It also was important that 2005 Tyrone had a blinding football team, and in fact went on to win the All-Ireland that summer, beating whoever those guys in green and yellow are. You see in the middle photograph, there's a bit of blanket defence going on there as well. I'll just note in passing. There were some disadvantages about trying to do von Willebrand disease research in Ireland in 2005 because no one else in the country was interested in it, and no one was really doing coagulation biochemistry, hard science research at that time. So whenever I arrived in Dublin, the number of people interested in von Willebrand factor research increased significantly. So we were lucky at the beginning. We got some money from Science Foundation Ireland, some other people, and so we set up a von Willebrand factor research group. And so that research group has been pretty successful, I think it's fair to say. So for example, over the last 15 years, we've had in excess of 12 million euro in peer-reviewed competitive grant funding awards. So that would stack up, I think, pretty favorably against virtually any von Willebrand factor lab in the world. So I'm not going to go into all the science research that we've been doing, or Scientology, as my nephew likes to call it, but I'm going to talk about the Low VWF study, which is clinical research, which I think will be the most interesting part. So the idea of the Low VWF study, which is looking at low von Willebrand factor, really came from thoughts that Evan Sadler, who many of you will know, published back in 2005. So Evan published a number of papers, including this one. And what he said was that, as this is von Willebrand factors, the orange line, as your von Willebrand factor level falls off, your chance of bleeding, which is the red line, increases. So when you get down to really low von Willebrand factor levels, there's more bleeding. But interestingly, here's the lower limit of the normal range at 50. You can see even once you drop below 50, your bleeding risk starts to increase. So even a mild reduction in von Willebrand factor, Evan hypothesized, might be important in bleeding. And so that kind of, those observations that he made led to the kind of where we are at the minute. So normal von Willebrand factor levels are kind of in the range of 50 to 200. People who've got type 3 von Willebrand disease have no von Willebrand factor. People who have got type 1 von Willebrand disorder have got levels between 3 and 30%. But the majority of patients are going to be in this category, this low VWF category, where their levels are between 30 and 50. So this low von Willebrand factor group is important. It's the commonest type of von Willebrand disorder, accounting for 60% of, for example, patients in Ireland. More than 7.5 million people in America are going to have low VWF. But there are a whole bunch of questions, or at least there were when we started to kind of get interested in this 10 years ago. So does it run in families? What genes are involved? Because we don't know what genes are involved, we can't give proper genetic counseling. Do some or all patients with low VWF have bleeding problems? Do patients with low VWF need to be treated for operations or procedures? If the patients need treatment, then what's the best treatment? And when we started the Low VWF study, there were 0 studies that had been done to that time. So back in 2014, we started this Low VWF study, the Low von Willebrand Ireland cohort, or Low VWF study. And it's still running, I'm pleased to tell you all. So some people have made really major contributions to this study over the last 10 years. The study started off with some funding from the health research boards. So we had a scientist, Sonia Guila from Spain. We had a research assistant called Niall Dalton, who's now a junior doctor. And of course, then Michelle joined as the clinical fellow in 2015. And the design of the study was incredibly simple. We got ethical approval, and then we started recruiting patients when they were attending the National Coagulation Centre for their routine appointments. We completed a questionnaire with them about their previous bleeding, and we took some additional blood samples. At the time, they were having their normal blood samples. So that was, the design was very simple. We got some pretty outstanding international collaborators involved. People in von Willebrand disease will know these two guys, Paula James in Canada and Jorge DePaulo in the States. And so these were the first data that we published from the study that actually went into Blood in 2017. So Blood, many of you will know, Blood is the #1 hematology journal in the world. So this was the data on the first 126 patients in the Low VWF study. The first thing that we saw that was interesting was that almost 90% of them were female, average age 39. And if you look at the people who are registered in the Irish registry with low von Willebrand factor levels, you can see that the people in the study were pretty reflective of the people that are in the registry in total, particularly this female predominance. We checked the blood group for all the people in the study because blood group affects von Willebrand factor levels. And almost 90% of the people were blood group O, which is a big overrepresentation because only 55% of the Irish population are group O. So this effect of group O, of ABO blood group with lower levels in blood group O has been reported across the world in all different types of ethnic groups, pretty consistent. So we asked all the patients that we enrolled in the study then some questions about their bleeding history, easy bruising, nosebleeds, periods, etc. And then we calculated a bleeding score using a pretty standard template that's now available to kind of get an objective measure of bleeding. So the first question we asked was, do patients with low von Willebrand factor registered in NCC have significant bleeding? And the answer was definitively yes. So more than 70% of the patients who we were studying had this objective bleeding score was increased, and in many of them it was very significantly increased. So some people with low von Willebrand factor levels do have very significant bleeding. What kind of bleeding do they have? Well, this is where Michelle really got going. So the kind of things that stood out for us were that they had heavy periods, dental bleeding, and postpartum hemorrhage. That had never been described before. Is the bleeding in low von Willebrand factor of clinical significance? Again, definitively the answer is yes. So like almost 90% of the women with low von Willebrand factor in the study had heavy menstrual bleeding, and more than 12% of them, astonishingly, had required a hysterectomy or ablation for that bleeding. Not only is the heavy menstrual bleeding important clinically, but also the postpartum hemorrhage is important. More than 60% of the ladies had had a postpartum hemorrhage, and more than 20% of those had required transfusion or critical care support as a result. So those numbers are actually kind of frightening, I think. And when we looked at the patients, even though they were being followed up in NCC, where we were looking at their blood counts and were trying to stop their heavy bleeding, many of them were becoming iron deficient. And, you know, iron deficiency affects many aspects of our life, and it definitely affects quality of life. So this iron deficiency, even in a tertiary referral center that's specifically looking for it, is showing you that these ladies are bleeding for sure. So why are they bleeding when their von Willebrand factor levels are only a little bit reduced? So we looked at all the people in the study, in the Low VWF study, to see whether they had other clotting disorders. And we found some things, but I guess the take-home message is in the vast majority of people, besides their borderline reduced von Willebrand factor levels, we didn't identify anything else to explain their bleeding. So this is a big question that we have, is why are people bleeding so much when their von Willebrand factor levels are only a little reduced? So we know that von Willebrand factor levels increase with age. And so that raised the question as to what happens to low VWF people as they get older? Could they, if you like, grow out of their low VWF? And so we looked at levels in the patients over time. And for sure, in some of the people, we do see that their levels go from less than 50 to above 50. But what was interesting was that although the von Willebrand factor levels were going up with age, whenever these people were having operations and procedures, they were still bleeding, suggesting that the increase in von Willebrand factor levels with age is not enough to stop the bleeding risk. Similarly, von Willebrand factor levels go up during pregnancy. We saw in the low VWF people that the VWF levels went up. They went up more than 100 in lots of our ladies. But in spite of that, lots of these ladies were still having significant postpartum hemorrhage, again suggesting that the von Willebrand factor levels aren't the only player here. So why are the von Willebrand factor levels reduced in these people? Well, this is the Scientology, I'm afraid. So there is a mouse that's got low von Willebrand factor, believe it or not, a naturally occurring strain of mouse, and that mouse has got low von Willebrand factor levels because the von Willebrand factor gets cleared too fast. And in our low VWF, in our low VWF study, we see that quite a number of the patients are clearing their von Willebrand factor faster than is normal. So that's probably a contributing factor. And that was published in Blood in 2019 as a second paper from the Low VWF study. So what are we doing now? That's kind of what we did before. Well, now that Michelle has graduated to be a consultant colleague in the NCC, we now have a new clinical fellow, Dervla Doherty. So Dervla has taken up where Michelle has left off. Dervla has got a very prestigious Wellcome Trust ICAT Training Fellowship Award. So hopefully this is together with Helen Fogarty, who's got the same award, hopefully this is the future of hemostasis in Ireland you're looking at here. We now have more than 200 patients in the Low VWF study. And so Dervla is working on that. And in particular, she's looking at what's the best way to treat low VWF people for operations. So as you know, we'll all know we use DDAVP widely to treat von Willebrand disease because it causes a transient increase in von Willebrand factor levels in the blood. We were interested in the question as to whether DDAVP would work in patients with low VWF. And this paper, which was published just in the Journal of Thrombosis Hemostasis earlier this year, shows that DDAVP is very effective. So hopefully lots more to come from Dervla on that front. So the low VWF group is really important. I think, as I said to you, it accounts for 60% of all the patients registered in Ireland with von Willebrand disorder. I think that's the tip of the iceberg. You'll have heard Michelle talk about this before. There are lots of people in Ireland with undiagnosed low von Willebrand factor for sure, who are suffering with easy bruising, heavy periods, and so on. So we have communicated these results widely, and hopefully lots of people on the call will have received the update on the study, this nice image that Michelle has put together with our data to date, but there's a lot more coming, hopefully. So to give you some idea of the kind of impacts that the clinical research and the science from Low VWF has had, Ireland is a world leader in some things, as you can see along the top there. In medical research, there's not many areas of medicine or medical research where Ireland, I think, can really claim to be a world leader. But for sure, I don't think anyone would argue with the statement now that Ireland is established as a world leader in von Willebrand disease research. So since 2005, we have more than 150 papers that have come out of Ireland in all of the top journals. And that's really what has led to the reputation that we have. That reputation has led to the fact that both myself and Michelle have been invited to kind of serve on the guideline panels for the UKHCDO and most recently then for the ASH ISDH World Federation of Hemophilia guidelines on von Willebrand disease. But I think, what's more important than the papers and the guidelines and the talks and things is the fact that this program is generating the future of clinical care for bleeding disorders in Ireland. So in terms of clinicians who have trained in this program, Ruth Gilmore, Fionnuala, Michelle are all established now international leaders in coagulation themselves. Jamie O'Sullivan, who's the top right there, is now an independent researcher in von Willebrand disease in Dublin. And down along the bottom, I mentioned Dervla already, but we also have Helen Fogarty, who's researching von Willebrand factor in sickle cell disease, and Ines and Niall, who I mentioned before. So this program is bringing out a whole host of people who are going to make sure that this program goes from strength to strength. And that's obviously important, really important for clinical care for bleeding disorders in Ireland. In terms of the research, the future of the research is that on the basis of the Low VWF study, we are now involved in the Zimmerman program. So this is a study that's funded from the National Institutes for Health, or NIH in America, to the tune of $12 million over 5 years. And so there are 3 PIs on this, principal investigators on this study, Bob Montgomery in the States, David Lillycrap in Canada, and me here in Dublin. So 2 of the 3 principal investigators are not in the States. And I can tell you that during the Donald Trump era, to get a program grant of this size from the NIH, where 2/3 of the money was not being spent in the States, was a pretty major achievement. So this is going to lead to lots of more discoveries about low von Willebrand factor and von Willebrand disorder in general. So with that, I'm going to stop. I just want to thank particularly all the patients who have been involved in the Low VWF study from its inception it continues to go on, and we're going to be contacting all the patients again once the centre opens up and we're seeing people in person again, because there are additional studies that we'd really like to do to build upon the premise that we already have. I'd like to thank the Irish Haemophilia Society and Brian, who give us regular opportunities to present this data, which is incredibly important in terms of making people aware of the data that we are generating. I want to thank all the people in the NCC, only a small number of whom are on this photograph, which we desperately need to update. And I'd like to thank all the people who have come through the research lab. Again, there's only a small number in the bottom right-hand corner over the last 15 years who really generated all the data. And finally, I have to acknowledge Science Foundation Ireland, who have really funded this program for 15 years and have been the cornerstone for all of it. And so with that, I'll leave it there and be happy to take any questions.
I'd just like to reiterate what James said, that we really appreciate the Irish Haemophilia Society given the opportunity to have this update for von Willebrand's disease or disorder. I do like disorder, but I'm a stickler for nomenclature, so I'll go with the official scientific term for the minute, but I like the adopted approach. And I've been asked to speak about the diagnosis and guidelines, but I am cognizant that there may be people who have come to this webinar might necessarily know much about bleeding disorders. So just for, I suppose, a brief overview to start with, that, you know, why do they occur? Well, if in order to make a blood clot, if you get an injury to a blood vessel, you need clotting factors and you need platelets. And these come together to stop bleeding so that it will, you know, you'll heal the blood vessel and stop your bleeding in time. And if this doesn't happen in a timely fashion, if you have a reduction in either your clotting factors or your platelets, because the variety of disorders that can affect these, then you can end up with bleeding symptoms. And von Willebrand disease is just one example of many bleeding disorders that exist. And these can result in bleeding symptoms, which many people on this webinar will have experienced and perhaps had difficult problems with, including nosebleeds, which is probably one of the most common symptoms in children and in men, easy bruising, which can affect many people. There may be bleeding during teeth brushing that could be excessive, or if they have cuts or minor wounds. Heavy menstrual bleeding is a huge problem for women who have bleeding disorders, and that's probably the most commonly experienced bleeding symptom for women, and it can affect up to 90% of women with bleeding disorders, depending on the specific subtype. Bleeding into the bowels or into the urine are less common, but can happen, and people will experience bleeding at times of challenges. So if they have teeth pulled, if they have surgery, or if they have childbirth, they can have quite significant bleeding if their bleeding disorder has not been recognized. And it's rare to get bleeds into the brain or to the joints. Joint bleeding, of course, is the hallmark of haemophilia, but it can affect people with type 3 or severe von Willebrand's disease. So we all tend to hear about haemophilia, and I think people are more aware of haemophilia in the general public than they are of von Willebrand's disease. But how common is haemophilia in relation to von Willebrand's? So overall, it's felt about 1 in 10,000 males are born with haemophilia. And how do we do at diagnosing haemophilia? Well, if you look at the European data from the World Fed report, that they're pretty much hitting that 1 in 10,000. So it's kind of where you expect it to be. Ireland seems to be doing a bit better here, but it is an inherited disorder that can run in families. So I think we're probably picking up quite a lot of the boys that are born with haemophilia. And how are we doing with von Willebrand's disease? Well, we've been talking about that, you know, depending on which study or which paper you look at, reduced levels can be found in, 1% of people when they've done epidemiological studies, but the combination of both reduced levels and bleeding occurs in approximately 1 in 10,000 people. 1 in 1,000 people. So if you take those figures, well, von Willebrand's disease should be 10 times more common than haemophilia. But when you actually look at, this is our numbers again to remind you for haemophilia, where are we for von Willebrand's disease? Well, per 10,000 people, okay, we're maybe, meeting the 1 in 10,000, but it should be 10 times more common. So we should be seeing 10 per 10,000. And when you look at that, we're actually lagging far, far behind, despite the fact that Ireland is topping the table here with 3 per 10,000. We're still missing many people who potentially have von Willebrand's disease. And this means that people are experiencing long-term bleeding issues without getting the support that they need or the treatment that they require. So I think it's really important that we recognize and that the public recognize that most people with bleeding disorders are currently undiagnosed. And why is this happening? Well, we're failing to recognize abnormal bleeding. And that's because your own experience is shaped to your, when you ask somebody, do they have heavy bleeding? They may often normalize that because you experience your own bleeding and think that may be normal. And that can be shaped by your family's experience. If you go to your doctor, it can be, if they think that they have heavy bleeding and they normalize it, that can influence your interpretation of normal bleeding. And there's also cultural taboos, which are quite significant when it comes to gynecological bleeding, particularly for women. And it's known that physicians miss opportunities to check or to diagnose bleeding disorders. So in a study looking at the US National Claims Database, and they looked at teenage girls with heavy periods. Now, this is a really high risk group. If you're a teenage girl and you have heavy periods since menarche, so since your first period that don't settle in response to treatment, then it's highly suggested that you could have a bleeding disorder. And the American guidelines and the international obstetric guidelines would suggest that you should be screened for a bleeding disorder. So when they looked at, they found almost 24,000 girls who had heavy periods, and they were coded for this. And of them, 1,000 had been either admitted or been treated for iron deficiency anemia or required a blood transfusion. And all of these girls should have been tested for a bleeding disorder by the current guidance. But in fact, they found only 8% had been tested if you had a heavy period. And even amongst the highest risk groups, so girls that needed to be admitted to hospital as a teenager because of heavy menstrual bleeding, only 16% had been tested for von Willebrand's disease. So we're again and again missing opportunities to identify patients with bleeding disorders. And even when people do test, they may not do the correct tests. They can rely on these coag tests, the basic coag test, which is insensitive to the most common bleeding disorders. So people may do a basic test and say, it's normal, you don't have a bleeding disorder. But in fact, that's very unhelpful when you're trying to diagnose a bleeding disorder. And bleeding symptoms are much more useful in predicting the presence of a bleeding disorder. So your initial assessment of bleeding needs a history, but that depending on your doctor's experience, they may not be asking the right questions. And that's where bleeding assessment tools are really vital to a bleeding workup to ensure that all the correct questions are being asked and assessed appropriately. And there's different types of bleeding assessment tools, and they perform differently in men and in women. So as a result of all these factors together, people with VWD are often bleeding their way to their diagnosis and having repeated bleeding or maybe worsening bleeding throughout their lives until somebody finally considers, could this be an underlying bleeding condition? And we saw in our Low VWF study that the median age of diagnosis was 33 for our women with bleeding disorders. So they had had 2 decades of heavy menstrual bleeding before anyone considered testing. And a third of women had actually attended 2 or more hospital consultants with different bleeding symptoms before they were referred to our centre. And it really can feel like snakes and ladders, depending on who you meet and who you talk to, that you might or may not get a chance to get your diagnosis and get your testing. And this leads on to why there are new guidelines. So the new guidelines were clearly needed to try and improve and standardize care and diagnosis for people with VWD. And what's great about these guidelines is that they involve both patient organizations, clinical organizations, basic science organizations, and methodologists in order to try and provide a really comprehensive overview of where the current literature is at and what the best practice should be guided towards. And these were needed because we have to try and standardize our diagnosis so that irrespective of where you are in the world, you can access your diagnosis, access the best treatments, and improve management for people with von Willebrand's disease. And this was quite a lengthy process. James was involved in the diagnosis panel and I was involved in the management panel. And we went through a number of different meetings, systematic reviews, a lot of Zooms, but at the end it went out for public comment and they've just recently been published. And there's 2 papers coming from this. One focuses on the diagnosis of von Willebrand's disease and the other the management. And I'm not going to go through them point by point. I'm just going to focus on some of the key areas because we did cover this recently as well in the IHS AGM. But just for those of you who may have not participated in that, the diagnosis panel looked at how you initially assess somebody presenting with a potential bleeding disorder, the use of bleeding assessment tools, the optimal use of assays and laboratory testing, and looking at what's the role for genetic analysis for patients with von Willebrand's disease. And some of the key areas that came out from that was that standardized tools, so you can capture that bleeding history correctly for an individual presenting, should be used. And in the primary care or with GPs, that if they are used, then they can be used to guide who should require testing or not. But if people have a family history, they should be still referred for testing, irrespective of their score. And in the haemophilia centres, they can be used to capture information about bleeding, but everybody still should be getting testing done, that they shouldn't be used to determine the need for testing. And what was very exciting about this part for me when I saw a lot of these guidelines was that some of the data and some of the decisions that were made on that were actually based on research that we performed in Ireland with our Irish patients. And that actually helped guide the panel towards what is the best way to use these bleeding assessment tools. So we could see direct results coming from the Irish research in the international guidelines. And in terms of the blood test and assays, they've now recommended a move towards newer tests that are more reliable to perform, because not all centres have access to the repertoire of blood tests for diagnosis of von Willebrand's disease. And it's hoped that this may improve access to care if these tests are more widely available. In terms of the threshold for type 1 von Willebrand's disease, we did touch on this in the conversation with James, about what a diagnosis should be, when should a diagnosis of von Willebrand's disease be considered. And for patients with abnormal bleeding, von Willebrand levels between 30 and 50 were used to confirm the diagnosis of type 1 von Willebrand's disease, what we would call low von Willebrand factor. But it is important to note that this kind of reclassification as potentially type 1 was largely driven by access to care, particularly in North America, where you really require a diagnosis of VWD to get payment or to get access to treatment. And they were worried that patients being called low VWF in these countries, they may not actually be able to access care. However, I think it's still important that we continue to look at and categorize people as having type 1 if your levels are less than 30 or 30 to 50 as low VWF, because we have seen in our research that people respond very differently to treatments in these different groups. And I think putting everyone together as type 1 von Willebrand's disease does a disservice to both subgroups of patients in order to try, when we're trying to really drive forward care and understand both conditions. One point that came out in the new diagnosis guidelines is that DDAVP trials are no longer recommended for adults who have levels in the 30 to 50 IU per deciliter range, so adults with low VWF. And for anyone who's gone through a DDAVP trial, it is a full day of coming in, having blood tests taken over sequential hours in order to assess your response. But based on the data from the Irish study, we were able to show that adults with low VWF respond consistently and perform very well in response to DDAVP. And instead of having that trial and that day taken out of your life, you can actually just confirm a response when it's first required for use. So if you have a procedure, you can come in and have your DDAVP, have a level taken afterwards to confirm you respond, and go ahead with your procedure. So that's really streamlined and improved processes for patients. And now it's translating, something we adopted in Ireland, but it's translating into international practice. In terms of aging, there was a question in the diagnosis panel as to whether you can outgrow von Willebrand's disease as you age, if your levels increase. And we know that aging will increase your von Willebrand levels, but it's actually now recommended that rather than removing the diagnosis, we should reconsider it. But there's no data or no evidence that actually your bleeding may completely stop if your levels go above 50 as your age. So I think that's something we have to follow really carefully and be cautious in how we approach patients who are older with higher levels. In terms of the management panel looked at general bleeding symptoms and bleeding in response to surgery, pregnancy and childbirth, heavy menstrual bleeding and its management, and the management of specific areas as people age, particularly cardiovascular disease, and how we can manage patients with von Willebrand's. They looked at a number of drugs that are commonly used, so tranexamic acid, DDAVP, VWF replacement therapies, and the use of iron replacement and hormonal therapies for the management of heavy menstrual bleeding. Some of the key points from the management panel has been that the role of prophylaxis in von Willebrand's disease, that there are patients who have a history of severe and frequent bleeding, that the panel suggests the use of long-term prophylaxis rather than no prophylaxis. And this is a major shift in terms of how we encourage the use of prophylaxis in patients with VWD. And they've stated that bleeding symptoms and the need should be periodically assessed, but there is hope that this will improve access for both physicians and patients for prophylaxis for people with von Willebrand's disease. In someone who has heart disease or develops a cardiovascular disorder, can we use antiplatelets or aspirin? And we always tell people from the very outset, if you have a bleed disorder, to avoid aspirin. So it often can be quite difficult then if a situation arises where a cardiologist perhaps suggests aspirin usage to prevent heart disease or to treat underlying heart disease. And really what the point that was made in the management panel is that we suggest giving the necessary antiplatelet or anticoagulant therapy over no treatment, but having that patient-centered discussion about what the risks and benefits are, and that should involve all the members of the multidisciplinary team involved in the patient's care, including the cardiologist, the hematologist, and importantly with the patient at the center of that discussion. And that assessment of bleeding risk and reassessment throughout the treatment period is really important in order to really, if somebody is running into problems with antiplatelet use, that they're identified early. For heavy menstrual bleeding, it's recommended using hormonal therapy or tranexamic acid over the use of desmopressin for women with heavy menstrual bleeding. But really the decision regarding treatment of heavy menstrual bleeding largely depends on the woman's choices regarding reproduction at that time. And if they're looking to conceive, then obviously hormonal options are not there for them at that time. And in that situation, tranexamic acid was still felt to be a better option than desmopressin in women who wish to conceive. But this was acknowledged that this was one of the areas in which we really need to do a lot more work in order to determine what's the best first-line treatment for women, because there's a lot of options here, the pill or the coil or tranexamic acid, but they weren't able to state with confidence which approach was actually better. So it does mean women have to often trial multiple lines of therapy before they can find control for heavy menstrual bleeding. A major change is the use of tranexamic acid after delivery. So how to prevent postpartum bleeding. The panel has now suggested the use of tranexamic acid in women with type 1 or low VWF and maybe with other types of von Willebrand's disease during the postpartum period to reduce the risk of postpartum bleeding. And this is specifically focused on bleeding that can occur after women go home from hospital. And I still think that we are not educating people enough, either obstetricians or our patients, about what the risk of postpartum hemorrhage after you go home is. And it's very common for women with von Willebrand's disease to experience heavy bleeding for even beyond 6 weeks after delivery. And this can contribute to fatigue and iron deficiency, and during a very difficult time of a woman's life where they already have a young baby at home. So how do our guidelines change practice in Ireland? Well, there are new thresholds suggested for type 2 von Willebrand's disease, depending on the numbers that are achieved during the laboratory assays. There's no DDAVP trials recommended now for people with low VWF, and that's something we've been doing in our centre, but now is rolling out internationally. There really hasn't been a huge amount of change in terms of what we do for post-operative monitoring. I didn't get into that a huge amount here today just because of the limitations of time. But in terms of how we follow people in the post-operative period, that would be really in keeping with our current practice. There's further support for the use of prophylaxis, which I think is a really important step for people with severe and frequent bleeding and von Willebrand's disease. The panel has really highlighted the importance of an individualized approach to antiplatelet use in patients who have cardiovascular disease. And now the use of tranexamic acid post-delivery and after childbirth to reduce the risk of bleeding. That's also a new change for both in Ireland and internationally. I think it's also really highlighted how important the Irish patient's contribution to research has been. Like, some of these guidelines have been developed because of the contribution from the Low VWF study. So we're really indebted to everyone that participated and supported that study in order to try and drive forward and improve change. So you can find these guidelines online. If you're looking for them, you can look on the ASH, so the American Society of Hematology website, or the World Federation website, and they're also available if you search under the guidelines for von Willebrand's disease. They are quite a lengthy read. I was going to say something to bring with you on holidays, but no one gets to go away anymore. So, and I think then, what's the next steps for von Willebrand's disease in Ireland? It's really, I think the key area is how do we recognize and diagnose people better? Because that's where we're falling down. I think if you can get into the system, you can get access to care, but people are really hitting barrier after barrier towards their diagnosis. And we know that heavy menstrual bleeding is a key bleeding symptom that many women with bleeding disorders will experience. And if we can diagnose one person in the family, we can reach out to other people who experience bleeding within that family. So we really are trying to find key ways to get people into the system, and then we can hopefully help diagnose other family members that could be affected. And when we talk about heavy menstrual bleeding, many women will say their periods are fine. And then you ask them questions, including, how do you bleed for longer than 7 days? Do you need to change your pads more frequently than 2 hours? Have you ever had clots or flooding, or do you have anemia? These are kind of key symptoms in order to recognize heavy menstrual bleeding. And the importance of heavy menstrual bleeding can't be underestimated, because it leads to iron deficiency, anemia, low energy, reduced cognition and concentration. And it also has a huge impact on people's quality of life. So we know that heavy menstrual bleeding is common in women with bleeding disorders, but bleeding disorders are also common in women with heavy menstrual bleeding. So there's a real opportunity to focus on this area in order to improve our diagnosis of von Willebrand's disease and reach those other family members who could be affected, and hopefully prevent younger members of the family having a lifetime of bleeding before they're recognised. And we've done a number of campaigns. This campaign with the Irish Haemophilia Society, Know Your Flow, was focused on reaching out to teenage girls to explain what is a normal period. And there was a little video animation. We did an Instagram campaign that was quite successful associated with that. And it had some really simple messaging, including the 7-2-1. If you're bleeding for longer than 7 days, more frequently changing your pads than every 2 hours, or passing clots than a euro coin, that any of these were signs of heavy periods that you really should discuss with your GP and consider blood testing. So I think that this will be key to move forward in order to try and recognise people and to really spare them that long period of bleeding before they get diagnosed. So to finish, when I look to the future for von Willebrand's disease in Ireland, I think, increasing awareness will be key, not only in Ireland, but we're positioned to do this on an international basis. And many of us in the centre work with international groups, both in Europe and say with EHAD, the EHC and the World Federation of Haemophilia, in order to advocate for people with bleeding disorders and improve recognition. I think we need to continue to refine and develop guidance that's evidence-based for people with von Willebrand's disease about the best treatments. And I think it's very important that these are co-created with people with von Willebrand's, that we're including patients' lived experiences in the guidance that we develop. And we want to lead best practice through our high quality research, as James has outlined. And we've been very fortunate that we've worked with the Irish Haemophilia Society as partners with this, and hopefully we'll continue to do so into the future. So finally, I'd like to thank everybody that participated in the study. That has made a huge difference and continues to make a huge difference to the international understanding of von Willebrand's disease, and particularly low von Willebrand factor. The Irish Haemophilia Society, the Health Research Board who funded the study, our collaborators, and here are just some pictures of the large team that we've assembled, but everyone gets involved in von Willebrand's research if they stay with us long enough. So with that, I'd like to hand back to Brian and welcome any questions. Thank you.